So welcome to the webinar, Implementing Locator Overdentures into Your Practice. It is being presented by Jeff Carlson, CDT. We're going to begin shortly. And with that, it is my pleasure to introduce Jeff Carlson, CDT. He is our Senior Implant Specialist. Jeff has more than 40 years of dental experience with almost 30 years focused on dental implants. Jeff is the primary author of a 300-page, fully illustrated cookbook created for restorative dentists, and he is the co-author of a corresponding auxiliary manual. Jeff co-developed a restorative-based training program that more than 9,000 dental professionals have attended nationally and internationally. As the senior implant specialist for NDX and Sequence, Jeff provides technical chairside support and lectures across the country on immediately loading full arch restorations and sequence-guided prosthetics and the latest advancements in implant technology. And it is our pleasure to have him on teaching this evening. Take it away, Jeff.
Thank you, Jessica. And that's all we have time for this evening, folks. Wow, it's so great. I enjoy doing these programs like this. I really do. I do have the opportunity to present live about 2 to 3 times a month, and I enjoy that a lot too, the interaction. But sometimes it's nice just to be in a little room by myself and just to share my inner thoughts with you all. Welcome to the program this evening. We've got a lot to cover, so I'm going to just get right into it here. So my disclosure that is required of me and any CE that we are offering through National Dentex, that I do have an affiliation, that I am a full-time employee of NDX and Sequence. If you will, please. So how many of you are nibbling on something right now? Maybe having a little dinner, maybe just having a little snack. But imagine that in your mouth, all that acrylic in your mouth, and has been nicknamed over the years as an oral wig. And isn't it amazing, this big piece of plastic that patients actually expect to be able to laugh and speak and eat and function with this in their mouth and enjoy life. Many of them do. So, there's definitely a place for dentures. And what we want to talk about is those patients who really want to take this to, their oral care to another level, and their ability to enjoy their social life to another level. However, to do that, there's a requirement from you as a clinician to deliver, whether it's a new denture, or the overdentures, which we'll be speaking about exclusively tonight. But bottom line, and I've been doing this as you heard for a long time, that a lot of times I start my lectures, I say, how many of you would be happy if you never did another denture the rest of your professional career? And the hands go up and the breeze blows my hair back. And I ask, well, why is that? Why do you not like doing dentures? And there may be a few of you that enjoy doing them, and that's wonderful. But the majority of people really don't like doing dentures. And a lot of things we hear is that, patients' expectations are too high. And and just sometimes dealing with that patient themselves. There's a lot of other issues that are going on with those people from a health issue. Many times as part of the challenge, or closed or collapsed verticals. A lot of bone resorption, ill-fitting dentures, and it's really hard sometimes to meet the patient's expectations or to even understand what their expectations are. So I found this video clip that kind of sums up. I wonder how many of you feel this way if you come in the morning and your front desk or someone says to you, "Oh, we have our denture patients are going to be seated in room 1." Oh, room 1. Okay, boy, can't wait to get there. Yeah, we're going to start in on all the wonderful techniques that we're going to approach dentures the same way that we did for the last 50 years. But you think about it, why feel this way? I mean, we have all these wonderful options for patients to make their denture life better. And, you're looking at $1 billion market here with all these different products and things like that. And I was at a friend's lab not too long ago, and he had all these little pamphlets. And I said, well, what are you doing with all those pamphlets? Oh, I was at a trade show and I grabbed a whole bunch of them. And I thought, I just looked at this title, recommended to new denture patients. And I thought, how, you know, just, I want to say demoralizing, maybe that's too strong of a word, but, you know, non-motivating to know that you're paying this money, you're going through these steps, and you're still going to need something to possibly glue your dentures in, glue your teeth in, glue your smile in. So really what tonight is about is how do we really help to change lives? And the thing is, changing a person's life. Many of you have probably done a nice set of veneers for a patient, maybe gone through ortho with a patient, and the results, the patients are just so thankful and grateful. It makes you feel good about the profession that you chose and all the hard work you put into being the clinician that you are. And as far as many of you out there too, our lab auxiliaries, I believe, are tuned in, and I appreciate you all too. So one of the things that we know about overdentures, again, it was our topic is tonight. And a lot of this I'm going to share with you carries over to whether it's crown and bridge or fixed prosthetics, the all on X type of restorations and procedures and treatment modalities. So one of the things that in back doing this book years ago, working with some very top, I feel some of the top people in the country in dental implants, we keep talking about, pre-surgical treatment planning. That's so much an important part of the success. Create your plan, create the plan, work your plan. And so I really focused with some of my clinician friends and said, okay, so really let's talk about what is that patient. If you're trying to find the right patient, what's the criteria for doing that as far as your patient selection? And some of the things, we came up with a 4-step process, and I've been sharing this for probably 20 years now, and it's served myself very well, and clinicians I've worked with, I've heard from them, and it's worked very well for them. I'd like to share it with you, and hopefully it'll do the same for you. We came up with this concept of a 4-step concept for pre-surgical treatment planning. And the first one is patient expectations. What does a patient expect the restoration to look like, feel like, and function like, and cost? And we'll talk more about that. Then once we know what their expectations are, that's going to then drive us to the next step, which is restorative options. And then once we know what we're going to fabricate for the patient, then the next step is biomechanics. How do we design that restoration to meet the patient's expectations? Because biomechanics varies on the type of prosthesis that you're going to be providing for your patient. And then once you get 1, 2, and 3, then it's number 4. How do you share all this information with your implanting surgeon if you're not doing it yourself? Or if you're the implanting surgeon, share it with your restorative doctor, with your laboratory, even with your team members, of course. And even don't forget your implant reps. Some of these people are very knowledgeable, very talented. They have a lot to offer, and they can really help you through many of these implant procedures as well. So let's take a look about this a little bit deeper. So patient expectations. That's really the first thing your dialogue should really start with that with the patient. And keep in mind, everyone has a story, and you need to allow the patient time to tell their story. And sometimes it takes some encouraging them to want to open up, especially if they're maybe new to the practice. Sometimes it's easier for them to open up to someone new versus someone they've maybe known for many years, and they've realized they've been neglecting their own mouth and they haven't seen you in 4 or 5 years. And, you've seen those patients, I'm sure, as well. But patients' expectation is, what do they expect the restoration to feel like, function like, look like, and cost? And this is very important when we're talking about overdentures. Of these points here, I'd really want to point out the function. And function and feel could be similar, but function has really to do with movement. In other words, when you have implants, we have options of having fixed removable types of restorations. And someone's expectations might be that they're getting implants. So, oh, this would be great. It's like having my own teeth because they've seen commercials on TV, or they've talked to friends that says, oh, honey, you're going to love it. I got 2 implants that got rid of my denture plate. And denture plate, I mean, the terminology people use, who knows what this means to them. Um, and this is a particular case I'm recalling. And this patient told her friend, I got rid of my denture plate. I got 2 implants. It's like having my own teeth. Well, come to find out, so we did the procedure. We did 2 implants. We did an overdenture. Patient found out when we delivered it that it actually moves. And she couldn't understand why this moves. So we said, well, it has to. It's only 2 implants, and we can't have all your biting forces on 2 implants. And she says, well, my friend got 2 implants and got rid of her denture plate, and and she doesn't take it in. And then she found out it comes in and out, and it was like, oh my gosh, we had to calm her down, put her back in the chair from the fact that it's moving and it's removable. Well, come to find out, the denture plate was a partial, and no, I needed a 3-tooth bridge. 2 implants supported. So expectations, again, you really need to take the time to have the patient share their expectation. Tell them, have them explain their story. How do they get to where they are at, and where do they want to go? Where do they see themselves as a result of treatment with you? Because if you don't know that, everything else is going to almost be not necessarily irrelevant, but it may not be relevant to meet that patient's expectation when you deliver the final prosthesis or the definitive prosthesis. So very important to understand that. And cost, we'll talk, a little bit more about that as well, because a patient may have an expectation of, I want to have something that's not removable. Let's just call it, for ourselves, talking to each other here, the all-on X, where it's like have my own teeth. I don't have to take anything in or out. Well, there's a cost associated with that. But let's say that they have in their mind a price range that they can afford. And there's a lot of prices. Good news, bad news, folks. There's a lot of information on YouTube. And maybe they, in their mind, they have a price that they're thinking that they can afford to spend on their treatment. Well, their cost, their budget, if you will, might be here, and what they're expecting might be here. And so part of your challenge too is to keep the expectation in line with their willingness to invest in their long-term oral care, if you will. So that's very important about patient expectations. Many times that just gets overlooked because the patient says, "Oh, I just don't want my teeth coming out of my mouth when I laugh or eating, things like that. That's all I'm looking for. I just don't want to come propelled out of my mouth." Well, that's great. But there's other patients that are looking for a lot more than that. And you need to make sure that you know what that patient's looking for. And then the next is, now that you know what their expectations are, then now that'll drive you to the restorative options. In other words, if they didn't want their teeth to move or be removable, let's say, well, okay, an overdenture, if they don't want it removable, an overdenture is not for them. If no movement, in other words, a locator is going to have movement unless you put it on a bar and you use 4 locators, then that would eliminate that movement. But if we're talking about something that's economical, can be a nice improving the quality of life for them by 2 implants, say like especially in the lower mandibular arch, which Dr. Gordon Christensen many years ago said that 2 implant on edentulous arch, 2 implants overdenture really should be standard of care. So if we're not providing that for our patients, at least offering it to them, we're not even offering the standard of care. So this is it's a very viable treatment option. And I'm going to show you a lot of tips and pearls tonight to help you be successful with that. So the restorative options now, based upon their expectations, then you would know if they just don't want it propelled out of the mouth during laughing, function, chewing, eating, things like that, then probably very well could be a 2 implant overdenture would be very fine for them. So then once we know what we're going to make, then our next step is going to be, how do we design that prosthesis? How do we just, where do we place the implants? How many implants? And, there's a lot of things that you need to take into consideration with this. And then once we know what we're doing with 1, 2, and 3, then again, it's back to the team concept. How do we share that so everyone's on the same page, which is always focused on the patient? So patient expectations, sometimes it's challenging because perspectives are what our expectations many times are built upon. And perspectives are really in the eye of the beholder. For example, I'm going to bring a photo up here. In my lectures, I would say yell out loud if you see someone, if you're looking at someone frontal view or side view. So you can yell out loud, unless you want to bother your friends in the other room or your family in the other room. So this comes up. All right, what are you seeing? Are you seeing someone from the frontal or a side view? So if you're only seeing a frontal, or many people I think maybe see the side, whoops, sorry, the side view. So looking at a profile, this is the profile view. The frontal view is just straight on, except instead of having the face divided right down the center, it's kind of a curved line dividing their face. So again, it's just perspectives. And that's what's very important, is to really try to understand, put yourself in that patient's situation, and understand, and encourage them to, share their story with you. So I've talked about this already a little bit about no movement. It's a very important thing to have a conversation with the patient. Is minimal movement okay? Because then talk about that. Models are going to be very helpful if you have demonstration models that can have a patient feel what it's like. It's feel about that movement and the snapping of the attachments and so forth. Again, is it just mainly more stability, improved stability? And then very importantly, that gets overlooked many times, is to have a conversation with the patient about bone loss. Many times patients really don't understand that if they've been in dentures for a while and they've had the relines, they think that their denture has worn and that reline is where the plastic had worn away, not realizing that is resulting from their bone melting away. And I use the word melting away because if you tell the patient resorption, bone resorption, they won't know what that means. In fact, your computer, if you type in the word resorption, it underlines it in red because it doesn't even understand. And keeping in mind too, that, patients, they say that patients have a dental IQ equal to that of what grade do you think? Give you a moment. The average dental patient has a dental IQ of that equal to about a 5th grade level. So it doesn't mean we're dealing with, uneducated people. And when it comes to dental terminology, we just make that part of that dental ease just flows out of our mouths, but it means many times the patients do the patient bob. Oh yeah. And you say, any questions? Oh no, thank you, doctor. You walk out patting yourself on the back and they go, so Mary, what did he say? What did she say? What do they mean by that? And so then they bring it back down into terminology that they can understand. So I say that because many times when a patient explaining to you, telling you their story, and they talk about, like, I want to have my denture anchored into my jaw. Use their words, use the words anchor, because they understand that. We're talking about how they implant and and the attachments and how these things, and make sure that they're understanding that verbiage that you're using and that they are using as well. So the thing about patients needing to understand the effects of bone loss, it's a challenge for you to share that with them. Um, Unfortunately, as clinicians, I should say, we understand what we're looking at here. You look at these models, we know probably what the facial or aesthetically, how that patient would present. In other words, normal profile, more bone loss, the witch's chin, they call it, where the nose gets closer to the chin. That's an effect of bone loss. Well, how do you share this with the patient so they understand the value of maintaining bone? And keep in mind that dental implants, they've had a nickname for as long as I've remembered, and that they're called bone maintainers. Because if you placed implants into an arch and never restored it, it would help maintain the bone and the alveolar ridge. The body doesn't recognize the implant as a foreign object. It thinks it's like the root of a tooth, so it stays there, unless there's periimplantitis or there's too much stress, so forth and so on. So there are, as we all know, there's different stages of the bone resorption. And I think this is important for a patient to be aware of as well, because when you do immediate extractions, let's say, well, here's the available bone, the alveolar ridge, and we don't know to get to this point here in the bottom left, Is that 5 years? Is it 8 years? Is it 10 years? It varies and it depends, right? But we do know they're going to continue to lose bone over the course of their life. And so one thing you can very comfortably say to your patient that your dental treatment therapy will never cost less than it will today. And what do we mean by that is that, if you were to look at this patient here in this situation, top right, and lots of bone, bone width, bone height, and you could probably put in two good size implants, give good stability, maybe do the same here in the bottom left, but now you get to this in the center bottom row here, and now you don't have very much length available. The bone's narrower, and two implants maybe not be enough biomechanically to support that. So now you're going to need four implants or maybe three implants. But the point is that it's going to probably cost more and maybe even take more time. Maybe there's bone grafting that's needed as well. Bone grafting is going to add more cost. So that's why I think it's comfortable to make the statement that your treatment will, really will not cost any less than it will today. If you wait longer, it could cost more because things change, and maybe those issues will have to be addressed that aren't needing to be addressed right now. And I saw this, I've had this picture for many years, and this is really a powerful one. When I first saw it, I thought, my gosh, when you look just at the edentulous mandible here, but when you put a tooth on it like this, of course, that's just a shade tab. But that is really something. And, these are things to the degree you can share that with your patients, it's really going to help them to build value, perceived value, and what the treatment modality you're offering to them. And it's kind of, we all as humans, we do things for our reasons, not necessarily for others. And so to help them to understand their reasoning for this is very helpful. I strongly suggest that you get these set of models. They're on a board that's probably a 12-inch board. And these are plastic mandibles, and they're easily to remove off this board. They're available from Salvin Specialties. It's just www.salvin.com. And I think they're less than $100. And what's so nice about these is that you can give the patient something three-dimensionally that they can touch and hold and look at. I'm surprised that patients, really understand radiographs. Like when you show them a panel and you point out, where their bone is, and maybe point out other radiographs with like these, that you can show a patient that, someday, this is what this looks like radiographically, and intraorally, that's what some of these things look like. So, again, it's whatever you can do to help this patient to understand the condition that they're in, and that what you're offering them is a real viable option and they can truly benefit from it. So talking about bone loss, what's very interesting about this, to try to bring this point home even more, is that a good friend of mine, Cynthia Bollinger, started an organization many years ago called Institute for Dental Implant Awareness. And there's their website. It's missingteeth.org. It's .org is the important one. And it's a patient-dedicated website. It's not sponsored by any implant manufacturers. So there's no hidden agendas there. But one of the things that she did and her team did is they surveyed patients that were given implants as an option and said, no, thank you. They came back and really explained to them what the consequences of bone loss was, maybe utilizing some of the ways that I shared with you. 65% of the patients, once they understood that, said, okay, I'm in. Let's go ahead and go forward with the treatment because they want to preserve bone. So preserving bone is very important. So let's look at some of our options for the edentulous arch, for treating edentulous arch. In the laboratory, we get asked routinely, how many implants does it take to get rid of the palate of this denture? And the answer to that is really 4 implants. And you're still going to need, ideally, you should have a cast partial frame understructure for the acrylic work when you're going palateless, because that still can be a lot of forces generated, a lot of biting forces generated. And it's without that metal, you're still dealing with plastic. And if a patient has 4 locator implants, and based on the retention level that you use in the inserts, there could be very significant biting forces, both biting forces as well as pulling forces with maybe more of a gummier food, so to speak, and just the patient maybe taken in and out. So that I want to just kind of share that with you, that really it's 4 implants to get rid of a palate and a denture. The other option we talked about a little bit about, mentioned the All-On X, a hybrid prosthesis, All-On 4. Of course, is a brand brand registered trademark with Nobel Biocare. All-On X is a term that's utilized. Meaning instead of All-On 4, maybe it's All-On 5, maybe it's All-On 6, 7, or 8. So it's All-On-X. So if you're ever wondering why do they say All-On-X, that's the rationale for that. So to do these All-On-X cases, you're looking at a minimum of 4 implants to about 8 to about 6 implants. Sometimes people will do more. Then fixed bridge work, when we're talking about more of a crown and bridge prosthesis, we're not doing a lot of alveolar ridge reduction. But we're looking at probably 6 to 8 implants to support a full arch of more crown and bridge type of restorations. So one thing that we've learned over the years is more isn't always better. I had a doctor actually show me, I showed this at a lecture not that long ago. And after the meeting, he pulled out his iPhone and he showed me a picture, not too unlike this, where he inherited a case where there were implants for all over the place, laying everywhere. So more isn't always better. So let's get back focused now about more of the locator and the overdenture concept. So when it comes to attachments, they're in 2 categories. There's what's called a resilient or rigid attachments. There are 2 categories. And so a resilient attachment is an attachment or a component system that allows for movement of the prosthesis during function, which is very importantly because that's how you distribute loads. And as we all know, the key to long-term success in implant dentistry is how do you distribute the loads generated during function in a greater area as possible and as quickly as possible. To the degree that you and your team are able to do that, that's where we see the long-term success. That, of course, and with patients' home care. So resiliency is utilized when we're doing fewer implants. You're definitely going to be utilizing the resilient type of attachments. Rigid attachments are wonderful attachments as well, but those are typically going to be utilized onto a bar of some configuration. And so they're going to be sometimes clips, but they're going to be more rigid. They're not going to allow for a lot of movement during function. But they're going to help to hold the prosthesis in place, keep it stable. But when loads are generated, usually think of it as an implant-supported prosthesis. So when the patient goes into function, that load's going right to the prosthesis, to the abutment, to the implant-to-bone interface, and next chewing stroke. So when we think about some of the restorative options, again, we're going to really focus tonight on the overdentures. Bar support is still a viable treatment option. We're seeing more and more of the All-On-X type of cases. And then we're seeing a lot of the fixed prosthesis, which if any of you have been through any of the Dr. Carl Misch training, written any of his books, Misch Institute, been through the Misch Institute or any of his books, he talks about the classifications of FP1, FP2, FP3, FP4, so forth. FP stands for fixed prosthesis. This is an FP1 over here on the right, where we're seeing a growth in that area where people aren't, those cases, you don't have to do as much bone alveolar reduction, alveoloplasty to get room for the prosthesis as you do with the All-On-X type of cases, which are also referred to as an FP3. Okay, so the benefits of Locator, they've been around a long time. I tell you what, it's like the mousetrap, the dental mousetrap, in my opinion. It was done right early on, and there's been minor modifications to it. I'm going to share with you on the end to this presentation. What's new now is they have a fixed Locator, which is really slick. You can convert a Locator overdenture to a fixed prosthesis. That's right, fixed, utilizing existing implants and existing Locator abutments. So I'll say that to the end. So the benefits, it can be, as far as a surgical procedure, minimally invasive. Based on the conditions, it may even be a flapless surgery to do this. There's also the ability to retrofit existing dentures, where if the patient's happy with their denture, you're happy. It's just, they just don't have the alveolar ridge isn't there to support this denture. And so a couple of implants, that denture can be retrofit. I'm going to show you clinically how to do that chairside as well. So let's talk about the drawbacks for a locator. That there's still mobility. They still need to be relined. Patients still are going to have, bone resorption, bone loss, bone melting away in the posterior edentulous ridges area, typically. The cleaning of food, because there's some movement, food can get underneath there, but good news is the patient can take it out, rinse it. And that, the attachments do need to be replaced, which I really don't think is a drawback, because denture patients, they don't think they need to come to see the dentist because they don't have any teeth. And you still want to see your patient on, at least an annual basis, your edentulous patients for, oral cancer screening, et cetera. So attachments, these overdentures, I think it's in the drawback column. It might be a drawback to the patient, but truly, it's a benefit to them. So the thing that we need to take into consideration for patient selection also is the available bone. So what we've found over the years is that the average diameter implant is 11 to 12 millimeters. The average length of an implant is 11 to 12 millimeters. The average diameter of an implant is 4 to 5 millimeters. Right around 4 millimeters is kind of like the average diameter. And most clinicians will feel that if I can get an implant in here that's a 4 by 11, 4 by 12, even maybe a 4 by 10, probably going to be pretty good in supporting the prosthesis. But keep in mind that there's so much bone that needs to be surrounding an implant. And what studies have shown us over the years, that ideally you want to have 1.5 to 2 millimeters of bone surrounding an implant so that there's enough vascularity to regenerate the bone cells. 1 millimeter probably on the shy side, but we see cases with a lot less bone than that, and they still work. But again, we're talking about for optimum results and really trying to minimize as many variables to failure, if you will, as possible. So we're looking for bone volume of a minimum of maybe 10 millimeters of available bone. This isn't, because you got to think about the mandibular nerve. You can't be, you can't come right to it. You got to stay 2 millimeters away from the mental frenum and the mandibular canal. So you need 10 millimeters of bone above that, actually like 12 millimeters of bone above that, based on the length of implant you're using. But the ridge width is also an important part. Bone's evaluated three-dimensionally, height, width, and depth. Height, width, and length. And so the width is about 5 to 6 millimeters. That would give you, if you did a 4 millimeter diameter implant, that gives you about 1 millimeter, really kind of the minimum amount of bone around an implant. Then we also need to take into consideration the restorative clearance. And this is where people get into trouble sometimes, based on the type of final prosthesis you're looking for. That their restorative space is typically, it's going to be measured one of two ways. It can be measured from this is commonly measured one of two ways. There's other ways of measuring it, but it's either measured, when we talk about locators specifically, a lot of times we're talking about the tissue height. So from the crest of the gingival tissue, from the crest of the alveolar ridge, the gingival tissue to the occlusal plane, all right, to that occlusal plane. For a locator, for example, we'd like to see 5 to 6 millimeters of space, and I'll show you more actually intraorally some photos about that, measuring that. When you get into your all-on X cases, you could be as much as 15 millimeters. Now that's going to be measured, typically those are measured from the platform of the implant, which is also commonly the platform of the implant is placed at the crest of the alveolar ridge. So that means from the platform of the implant to the occlusal plane can be as much as 15 millimeters or even more. Some of the restorations out there, you can get to about 11 millimeters. And some companies have some other options for your all-on X, maybe even a little bit less. The point here really with this slide is to make you aware that there is a certain amount of room that you need. And so you need to be evaluating that when you're determining, is this the this patient going to be, are you selecting the right prosthesis for this patient? Then, of course, the finances are very important. And patients' home care, their ability to take care of their prosthesis. In other words, many patients have poor vision, they're arthritic. And what are you fabricating if you're doing a bar or something like that? Can they get a floss threader underneath that? Or maybe it is better to have freestanding abutments where they can just throw some yarn around that, soak in some Paradex or something and clean that. So, want to keep that in mind too. And then opposing dentition, things like that will really help to determine what we have for the patient. I show this slide as just kind of give you a visual on when we talk about interarch space, what happens when we have tooth loss and bone loss. So as you see here, the blue line, a horizontal line here, represents their VDO, their what we refer to as your functional vertical dimension of occlusion, which is where your teeth come together when you swallow. That's your functional vertical dimension of occlusion, your centric occlusion, if you will. So now, that's maybe where many of us are at this point here, but I like to think. But if you don't change your VDO, but bone resorbs, you start seeing an issue here. And the issue is crown to root ratio. In an implant dentistry, we call it crown to implant ratio. So just be aware when we have bone loss, that's the other thing we have to think about is crown to implant ratio. And crown to implant ratio, ideally for long-term success, should be a 1-to-1. In other words, if you have a 10 millimeter length implant, the prosthesis shouldn't be more than 10 millimeters taller than that. Now, that really pertains more to get into your crown and bridge restorations, but it's still something to take into consideration when we're dealing with, even full arch. The good news about full arch prosthesis and why, for example, an all on X type of case can get by with these tiny little prosthetic screws to hold in, say, 4 implants, 4 little screws, and a full dentition, a full arch dentition, is because of something called cross arch stabilization. When you're able to stabilize a prosthesis across the arch, it changes the fulcrum or the cantilevers that are affected. When you do unilateral or single tooth or a unilateral bridge, you can have not only anterior, posterior cantilevers, but then the higher you get, you can have buccolingual cantilevers as well, or a horizontal cantilever. So why is the locator so popular? This is an old photo, but it's still, a picture says 1,000 words, and locator has the lowest profile, and that is very, very desirable because dentures, we still need it as plastic, right? And we still need a certain amount of thickness for strength. And when you get these larger type of attachment mechanisms, you're going to hollow out more of that denture. And based on how much room you have, buccolingually, vertically, this could be a little bit, you could be weakening the prosthesis. So getting back to our vertical space, that what we're looking at here, this is what I was referring to, that 5 to 6 millimeters. So if you imagine this patient was at their functional vertical dimension of occlusion, they were incentric, and all you did, their prosthesis is out of their mouth, and all you did at the same vertical, you just pulled their lip down, and then you're looking here and saying, okay, do we have that 5 to 6 millimeters? Now, based on where the implants are, you may need to have even more room because of where the denture tooth is going to go. So we have to take that into consideration of where the denture tooth would be. Another thing is about cuff height. Cuff height, collar height, interchangeable terminology. So here's an example that on the 2 abutments on the outside here, when you don't have enough cuff height above the gingival height, in other words, we like to see 1 to 2 millimeters of the platform of your abutment. In other words, the cuff height, the wall of that cuff or collar, to be at least 1 to 2 millimeters above the highest tissue point. If you don't have that, then what can happen is there's a higher propensity for tissue invagination or tissue ingrowth up and around. It becomes more difficult for the patient to maintain that from a home oral care perspective, and possibly even some more pain when the denture starts moving up and down. So here's a dramatic image of a patient who's had a lot of tissue ingrowth where the cuff heights obviously were too short. So again, we're looking to see that 1 to 2 millimeters above the cuff height. So when we're thinking about overdenture occlusion, some of the things to keep in mind, there's three forces of occlusion, three forces that are caused are a result of from the occlusion, the forces from the result of occlusion or functioning, if you will. The compression force is when objects get pushed together, and that's clenching. And then tensile force is the pulling apart, which we have that when a patient is trying to take their prosthesis out, with these locators. And then shearing forces, which are off axis. And those are the if you look here where it says that the strongest, the bone's strongest under compression forces, and it's the weakest under shearing forces. So we want to watch patients that come into occlusion that where don't have anything hitting on inclined planes, because that can cause, the shearing forces again are greater in that kind of a movement or that function. So biomechanical considerations that we're talking about, bone quality is a key, very important that we have to make some determinations of what's that patient's bone quality. And so I think most of you all know this is pretty fundamental. I won't spend too much time on it. If you're not familiar with it, look it up, read about it, because you need to be aware of this. Type 1 or D1, density 1. If you hear the verbiage D, D is in density, D1, type 1. This is typically the bone they'll say is you're find in the anterior mandible between the mental foramen and the mental foramen. They'll refer to that like oak wood. And the oak wood being really dense. Then type 2 bone is typically found in the posterior mandible, and that is going to be referred to as a spruce wood, for those of you that are familiar with wood at all. And then the softer bone that we find is in the premaxilla, type 3 or density 3, D3 bone, and that's referred to as like the balsa wood. And you'll also see through the schematics here, it's very trabecular. And then the softest bone that we have is most commonly found in the posterior maxillary, D4 bone or type 4 bone, and people refer to it almost as styrofoam. So this is important to know because it also has to do with how many implants that you're going to place. When someone's talking about treatment planning a case, there's something that you should always remember, and just kind of, I call it mumbling, for lack of a better term, is that you should always say to yourself, okay, 2 implants, all right, but it depends. Depends on what? It depends on what's the opposing dentition, what's the musculature like, is there parafunction, what's the quality of bone, how much bone is available. So you got to get that mumble going. Okay, so what's the opposing dentition? What's the musculature like? Is there parafunction? What's the bone quality like? How much bone is available? Those things will never go away, whether you consider them or not. They're going to be a key component in the long-term success of your prosthesis. So you better know what type of bone you're dealing with. If you're not positive when the surgeon places the implants, they should communicate that to you, because that's gonna, this should all be planned out ahead of time. You really, from CT scans, you can get pretty good ideas of bone density. Software today is able to, usually most software is able to read the bone density. So it's something to make sure you're taking that into consideration. So I also mentioned the available bone. Earlier I said it's 3-dimensionally, it's height, width, and length. Your panels, your bite wings, and so forth, they're going to give you the height and the length, but what's missing is that 3rd dimension, and that's where you're going to be able to, you really want to see, especially in lingual concavities. Boy, if you're not, even palpating, sometimes you get fooled on what's tissue and what's bone. So, CT scans are just really, I think, also, standard of care, for these types of cases. I think also, if you've been into implants, you're familiar with the anterior posterior spread, the AP spread. Now, for our locators, that's probably not so much that we're talking about here, but if we start talking about locators with a bar, which is a wonderful prosthesis treatment modality for a patient, but we need to know some of these guidelines. And Dr. Charles English, who's a renowned prosthodontist, and unfortunately we lost him, a few years ago, several years ago now. But Dr. English he came up with this AP spread back in like I think it was like 1986, somewhere around there. And what he told me personally was that he evaluated almost 1,200 cases where they were having fracturing on these, on our bar overdentures, fixed prosthesis, et cetera. And he found a commonality with them. First off, a lot of the breakage was happening at 5 to 7 years. The fatigue factor on the materials, there seemed to be about a 5 to 7 years, but he started seeing more of the fatigue factor on the actual materials. Not talking about acrylic, talking about more the titaniums and the alloys we used to cast with and do things, seems like 100 years ago. But the AP spread, if you take the two anterior implants and draw a line through the center two and a line through the two most posterior implants, and you measure that distance, the analogy here, the example is 8 millimeters. What Dr. English came up with is he looked at a correlation between the fracturing and whatever he could see, and he found out there was correlations in the distance the cantilevers were when they were having fracturing. So he came up with, I call the magic number, the 1.5. So you take that AP spread, the anterior posterior distance, multiply that 1.5, and that gives you, for this example, 12 millimeters. So 12 millimeters is the maximum that you should cantilever from the most distal implant. Now I ask you this, does that mean you automatically go 12 millimeters? Of course not. It's no different. Think of it as a speed limit sign. And you're out on the highway, and I'm up here in Minnesota, not that we have much snow this year, but if you're going around a curve and the speed limit sign says 55 mile an hour, but it's a blizzard out and it's been, you got ice on the road, just because it says 55, you're not going to go 55. The conditions changed, so you're going to adapt to that. Same thing here. You're going to look at this and say, well, okay, 12 millimeters, but what is that bone quality like? What's the opposing arch? What's the musculature like? Is there parafunction? How long is that implant? How wide is that implant? So this is what I'm saying. If you're not considering the mumbling points, if you will, they're going to affect your case. You might as well be aware of it so that you can design the case appropriately. Treatment, you have to treat the patient's conditions, physiological conditions, biomechanical conditions, and not just treat the wallet. You're going to get into trouble with that every time, because no matter what you're charging them, to you might be a really good deal. It's a lot of money to the patient, and their expectations still could be way up here. And you think you've talked them out of that all on X, and we're going to do a locator. They still have the expectation that's going to be like, have my own teeth. This is going to be great, even though I spent a third of the price. Their expectations are up here. You deliver this, and you're looking at, this is great. Lab techs going, hey, fist bumping each other. This is great. Patient's not happy. It's a failure. So guidelines are very important to have, but understand they're guidelines. You have to, think through these things. This is just an example of talking about arch form can actually affect your AP spreads. A tapered arch can often give you additional, better AP spreads. That fifth implant here, don't try and draw a line through that. Just that's your bonus implant, okay? That if you do this measurement and you did the math according to this, that fifth implant is just going to give you that much more security. Far right here, implants in a row, there's really no place to cantilever other than, maybe an attachment that allows the complete prosthesis to move posteriorly and vertically onto the edentulous ridge for support. So something to keep in mind too, cantilevers. In dentistry, cantilevers are really nothing more than magnifiers of force. And in implant dentistry, even more so, because we do not have a periodontal ligament. So it's basically, you're anchored in bone and you're cantilevering off, and something's going to have to give. And it's either going to be the prosthesis, the connection between the abutment and the implants, and or the implant to bone integrity of the interface. And that's where you get the saucerization. When you get cupping or saucerization, you get more food and plaque buildup, and can lead to periimplantitis, lead to implant failure, prosthesis failure, and so forth. So cantilevers, avoid them if you can. They really should be contraindicated when the patient exhibits any bruxism, parafunction. really consider occlusal night guards. Definitely want to consider occlusal night guard. Minimize the length of cantilever, and then use additional implants for sure if you're going to have to cantilever. And really, if you're using small diameter or short implants, avoid cantilevers. And if you can, cantilever to the anterior, not the posterior. Biting forces are 4 times greater at the first molar. So that way, if you do have something cantilevered out, that is not as hard of a biting force. So again, just evaluate all the factors: opposing dentition and musculature. Is there parafunction? What's the bone quality like? How much bone is available? And I think you're kind of getting that broken record. Okay, it will serve you well, my friends. Now, when we're thinking about, we have an edentulous patient and they're wanting to have some implants. Maybe today, right now, they're thinking 2 implant overdenture, because that's what they can afford. Maybe they're just concerned about, the procedure, a little fear of it. I don't want to get too overboard, too many implants, or financially, they just can't afford that. So we want to design cases, especially to my younger clinicians out there. If you're going to be practicing, another 20, 30 years, or even another 10 years, this is very important that you design cases so they can be upgraded. We see it happen all the time where patients start at one level because it's what they can afford at that time. Life changes, promotions, or they inherit money. That's happened a lot of the baby boomers. They're inheriting money, and now they can afford to do the all-on X type of treatments, et cetera. So this is something that Dr. Mish came up with, and it's in his book, um, several of his books. But what he did is, and I thought it was very brilliant, is divide between the mental foramen and the mental foramen, divided into 5 equal sections, calling them A, B, C, D, E. And when you're looking at his classification, OD is overdenture 1, overdenture 2. So an overdenture 1 is where implants are placed in the B and D position, and they're independent of each other. That is our locator, right? And then just another analogy where OD2 in his classifications is where you're connecting with a bar. By the way, whenever you can splint 2 implants together, studies have shown that they can withstand up to 50% more off-axis loading than freestanding ones, which is why our locators need to be resilient attachments to allow for that movement so that prosthesis can shift and capture the edentulous ridge to distribute the loads generated during function. So by doing those implants in those places, so now they want to upgrade, okay? Now you can drop in a couple more implants and either go to a bar, or maybe you could go to the all-on X, or maybe you add 5 implants and you do something fixed. So it gives you options to upgrade just by having the positions determine where you place those implants early on. So something just to keep in mind. The other thing I want to talk about, because this is difficult many times, is getting bite registrations on these edentulous patients. To no fault of their own, many of them that just don't have the proprioception. They don't know how they're biting. It's very difficult for them. They don't. A lot of them don't have what they would, in their words, they'd refer to a home base where we have our cusp. We have MIP, maximum intercuspation position. Our COCR. We have that. A lot of denture patients don't have it. They're just kind of skidding all over the place. So when we're taking these bites, or a functional bite, also referred to mush bites, and that's when you're putting say a bite wafer of wax, you soften it up in a flame or hot water, you have your occlusal rims, or maybe the denture teeth themselves, and a patient's biting into that. Well, what we know is that when a patient we go into functional closure, and based upon the bolus of food, that when we go into functional closure, that the mandible does a couple of things. One, as we get resistance, the mandible can actually, I'm going to exaggerate this so you can see it, might shift a little bit like this. And also more so, we see probably shifting left and right. Now, the challenge is you don't always see that, because with some patients, the facial mask, their very wrinkled face, you can't see some of that movement. And so what happens is, they when you get to their desired vertical, you say close a little more, and stop. That they stop here, they stop here. So this is a technique that I was taught a long time ago by Dr. Jack Frush, the founder of Swissadent, my mentor back in the 80s. And he shared this with me because we were talking about, centric ball bearing bite recorders and all these devices, which are still great, but they can be complicated and a little complex sometimes for people to use. So what he showed me was this, is he took a little piece of rope wax and made a pyramid of wax as you see here. He put it at the distal extension of a base plate, built it up about 5-6 millimeters tall. And he put it at the median suture line right here, center of the denture of the base plate for this extension. And I said, okay, well, what's that? So here's what I'd like you to do. Since someone's looking at you, you can do this and feel comfortable about doing this. I'd ask you to do this. Put the tip of your tongue at the junction of your hard and soft palate. Okay, put your tip of your tongue way back there. Try to move your mandible left or right and don't move your tongue. It's physically impossible to do that. So what he told me, he said, Jeff, this wax, show it to the patient and tell them to put their tip of their tongue on this wax. When they close, that to keep their tongue on it. And as they close, if their tongue comes off, no problem, just let you know, to tell them to let you know, and we'll do it again. But the tongue actually then acts as a centering mechanism. And I found in the laboratory, when I started doing these, I saved probably 15 to 20% of retry-ins due to just bites being off. In other words, the doctor would do a full double arch wax try-in on a denture, some bite material, blue mousse or PVS. So it looks great, Jeff, just process it, adjust the bite and process. Well, the bite was off. It's a whole reset up, re-wax and everything. So anyways, very simple. It works. It doesn't replace doing, I don't know if you're doing face bowls or things like that. If you are doing central ball bearing bite recorders, Gothic arc tracings, God love you. Keep doing those. Okay. So another thing I want to share a tip with you is that study models. With all good intentions, you're sending a study model of a patient's existing denture to the lab to duplicate. And the idea with that is patients might say to you something like, oh, no one knows I wear a denture, so I want my new denture to fit better and and fresh material, but I want everything to look the same. So what the assistant does then is they take their existing denture and they take an alginate impression, take a stock tray and fill it up with alginate, seat the denture in it. It sets up, pull the denture out, pour the model, and this is what the lab gets. All right, this model here, all we're getting in the laboratory is the arrangement of the teeth and the mold of the teeth, so to speak. We really don't know where do these two front teeth go, the centrals, in relation, labiolingually, incisally, which is critical when you're doing dentures. The laboratory needs to know where do these two front teeth go, labiolingually or palatally labially. They need to know the length. You need a good bite, good impressions, and a good laboratory can make you a wonderful denture. So we're just lacking information. This is something I've been talking about for many years, and it's going to take your assistant about 15 seconds to do, and it's going to be a game changer. So all they need to do is this: before the alginate sets up, is roll the alginate up over the peripheral borders of about canine to canine area, roll the alginate up, and posteriorly roll the alginate up over the edge back of that denture, leaving the borders here exposed so they can get their fingers on it to kind of tease that denture out of the alginate. Why is that important? Well, check this out. Now the model, when you pour that from doing that anterior roll, if you will, now the lab can take and measure that. And if you said, hey, the patient wants their new denture teeth 2 millimeters longer, now we have exactly what that patient has. So the lab can be very specific. Instead of just making occlusal rims that are 22 millimeters in the anterior and 5 posteriorly, 18 in the anterior, zeroing out to the center of the retromolar pads, which is what we've been taught to do for 40 some years or longer, this can zero in for your patient. So that helps give the length. But look what happens by that little roll in the posterior. Now this helps us get that labial position of the teeth. So if I were you, anytime I'm doing say the lab is going to make me occlusal rims, you're going to do, take a bite registration and you get something like this as a model to utilize, tell the lab to set 6 anterior teeth in, leaving the posterior occlusal rims, because now when you do your bite registration, you get to do an aesthetic evaluation at that appointment. So if the midline's not right, maybe it's not long enough, you take the patient through their F and S sounds, the 50, 51, 60, 61, Alabama, go through their phonetics to make sure, ideally your incisors should hit the wet and dry line of your lip, the vermilion border of your lip, just some little tips and pearls. It's just some guide, these are guidelines to help get you there. This is why people don't like doing dentures. No one's teaching these little tricks anymore. I have a whole denture course on that stuff that we're just implementing little bits into this presentation here. So hopefully you find that helpful. But I would actually get those 6 anterior teeth in all the time and try that, do your bite registration and aesthetic evaluation all in that one appointment. Okay, so here's the other thing. Now, good laboratories that know their dentures, they know this. You're not teaching a technician anything that's been doing dentures, what I'm showing here. But the cusp-fossa relationship, the occlusal table, should almost to a degree be dictated by the alveolar ridge, the anatomy, the prominence, if you will. In other words, when you have a flat ridge, the occlusal needs to be fairly flat. This is why you see what a lot of times laboratories will do. On the lower, there'll be a flat, very flat plane denture tooth, and they'll do what's called lingualized occlusion, and they'll have a lingual cusp of the upper maxillary first molar, making contact on that, and they're just translating across. But the cusp-fossa relationship is still masticatory enough to chew up that bolus of food. So something to keep in mind, that ridge has something to do with that. This is another neat little tool. I would encourage you all to get this. It's available from Ivoclar. It's called a bite plane. Last I checked, it's been a couple of years, but it's like $20, maybe even if it's more than that, a lot more. This is wonderful. This is not to replace a face bowl, but I gotta tell you that this can really help a lot. We have a challenge with that canter, whether it's an anterior, posterior canter, sagittally, or just left and right, front and back. So this is very simple. You put the occlusal rims, or they're even an existing denture, or you're doing a try-in and it looks like it's running downhill and you want the lab to adjust it. So this is plastic. You can take and actually put some tray adhesive on here, put some bite material on there, PVS material, heavy body, something like that. You go in the mouth and you seat it. If it's occlusal rims, cut your little keyways in there so it has a way to index it, and seat it, and then set it so that it's, as you see, it lines up with the inner canthus of the eyes right here. And then for, looking at your camper's line here, so we want to, keep that parallel. So that way, now you move it in the position, then let the bite material set up. Then when the lab gets that, they can articulate that, and then they'll see, oh yeah, that right side's down lower, they can reset the teeth. So a neat little device, very inexpensive, easy to use. Again, if you're doing face bows, don't stop doing face bows. I just know most people don't do face bows. This is a neat little trick for that. Okay, we ready for locators? All right. We did all that because if you can't be successful, or I'm gonna say if it's challenging being successful in the planning stages and all that, to even get to this point is it's going to be nothing much more than mental gymnastics. So hopefully that information I've shared with you has helped you to feel more confident and competent that you can plan these cases out properly, help a patient to understand what you're offering them, and for them to say yes to your treatment option you're providing them. So let's dive into the locator. So the locator abutment itself, there's going to be, most of our implants today are internal connections. And so the silver part of the multi-unit abutment typically is going to go into the implant. So we'll call this fixture level, probably also maybe bone level very commonly. On a locator, there's a fixed measurement of always from the top of the abutment down 1.5 millimeters on every abutment, regardless of the gingival height, GH, gingival height, also referred to as cuff height. So when you're getting a different height of a locator abutment, this is always that same. That's where that cap's going to sit down over that. You don't really have to know that. It's just I wanted to be aware of it. So locators, one of the beautiful things with them is they have different inserts that they're measured by pounds. So you got from 1.5 up to 5 pounds, and then they can function perfectly within 10 degrees divergence of another implant. So you're talking about 20 degrees divergence. They make something called an extended range, where if the implants are further off from parallelism to one another, then you're talking about going into this extended range, okay? The housing, the metal housing doesn't change here, but it's the inserts that change. This is the tool. If you don't have this, you've not done a locator in a very long time. They used to have one with a hook on it. This is a wonderful tool, multi-purpose tool, and you're going to see that used throughout here. One of the things that I didn't know a long time is this gold portion of the tool. When you unscrew that, there's a little plastic part here that snaps onto it. That helps to hold the abutment in place. But I didn't realize this for a long time, that inside that handle, there is a hex. It's a 0.05 hex in here. And so you could take an 0.05 hex driver, and that will go fit inside here. It's about halfway down. Well, here, as you see here. And then the other side of this gold handle, there's like a little triangular portion, the male portion that feeds into the top of the locator. But now what you're seeing here is a torque wrench, and you can torque that abutment into place. So that's one way of doing it. This is the more newer way, if you will, or more common way possibly. And the tool that can be a latch or for a torque wrench, this little triangle again fits in. It'll fit into the top of the abutment, and you can use your torque wrench accordingly for seating the proper preload or torque to the abutment to implant interface. There's a little device here, a little gauge, that the way you use that is you put your driver if you had a healing abutment. So let's talk about your trying to decide what angulation you may have here, fires divergence. This little tool, you set it behind it so you can read it from the front. There's a slot. It's blocked by the diagram here. But this one, if you were to line this up and you saw that driver holding this parallel was at 10 degrees or 20 degrees or so forth, it gives you an idea of what the divergence is. So let's talk about selecting the cuff height. Because if you're going to do, as we call here on our slide, retrofitting, you're going to bypass the laboratory completely. Sorry to my lab friends out there. But this is a great service to provide a patient who maybe has had a denture for 3-5 years, and they're just not happy with it, but their denture is okay. So again, I mentioned that seating area of the 1.5, the cuff height will vary, but what you need to do is to measure the tissue. And so a couple tips or pearls on this is using your perio probe. Be careful that when you're going down, one, you want to measure the highest point of tissue. When you're selecting your cuff height, look for the highest point of tissue. Then when you're seating the probe down, you're trying to catch, which you can do this, you're either going to catch bone or you're going to catch the edge of the implant. What you don't want to do, because most of the implants you're dealing with are internal connection or internal hex, is have that tip drop down inside, and you may hit a landmark inside the implant, and you get a false reading. So just make sure that you kind of push it out into the tissue and catch that. Oh, there it is, and measure at the highest point. And then again, we want to look at a measurement that's going to keep the cuff height about 2 millimeters above that tissue. So this will kind of give you an idea for that. Here's another little tip for you. Let's say that you get a case. So that was some considerations when you're going to do the retrofit. We're going to continue on with that. So I'm going to kind of share some tips as we go along here. If you happen to get a case, and this doesn't have to be even with overdentures, it can be anything. We have multiple healing abutments. The surgeon sent you the case back, or you place multiple healing abutments. They have different heights, different diameters possibly, and you take them out and you lay them on a tray. Someone bumps the tray, they roll all around. Now it's eeny, meeny, miny, mo. What you can do is take rope wax, shape it in an arch form, and just simply put wherever comes out of the mouth, put it in that arch form of wax. And that way, when you're ready to replace them, maybe you took some impressions, what have you, it's quick and easy. You know exactly what goes where. Okay. So now we're going to continue on with our retrofitting existing denture. So this is the case. These are not locators. These are some ball abutments, but it's another example to show you how to identify where you need to relieve inside that denture. So this is just one of those indelible little wood pins, inks. You wet it in the patient's saliva. You put a little dot of ink on top of the ball, and then you seat the denture on it. You get the little mark here. The other thing you can do is just without adhesive, just shoot a little blue mousse or fast set impression material there, seat the denture down, and it'll give you a little indication, your indents, and you know where you need to drill in and create these openings. So what we want to do is create a recessed area now inside that denture to allow room for the attachment. So here we've relieved that area, but how do you know if you relieved enough? So a guideline is this. Now, Zest attachments, they make special tools to do this. So I would say that I would encourage you to look into that because it makes life a little bit easier. It also has a tool that will create an undercut, cuts like a ledge underneath it that give you some mechanical retention beyond chemical retention. But what we're looking for, so let's say that housing is in place here, is you want to have a gap of 1 to 2 millimeters, no less than a millimeter, between the housing of your attachment and the inside of the denture, because you need to have this gap here to have a wide enough gap, because that's going to be picked up with your maybe it's Zest chairside acrylic, your Voco quick up, Stern easy pickup. Stella it has a nice material as well for using for picking up attachments. So, but you need enough thickness for strength is my point here. So now we've verified that we've got enough room. And so now we're going to get ready to pick up the dentures. We're going to put Vaseline everywhere except obviously inside the areas where the attachment is going to bond. And then we're going to utilize the spacing rings that come with it. Now, these spacing rings, they come, I think 2 come in a package, but you should go ahead and order an extra package of them. They're very inexpensive. I don't know if they come 20 to a pack, 50 to a pack, but many times you're going to need to put maybe as many as 3 or 4 of these little washers, these spacer rings. It's really a blockout ring. The insert that's going inside this metal housing is the black insert. That's called a processing insert. And that has to be utilized when you're picking these up in the mouth. So if the patient, so after we create our room, these spacers are going to make sure you don't get acrylic to go in and lock everything into place. So I have plenty of these spacer rings. So on this model, it was a perfect scenario. So spacer rings are in place. Now, another tip for you is this. Create what's called a vent hole. And I find a number 8 burr works about the best for this. You don't want to get much smaller than that. Bigger than that's a bit of an overkill. The key to this is you want to drill a hole once the housing is seated on the abutment, that you want to drill that hole so the hole is at the top. And the reason for that is I'm going to show you coming up, when we fill the inside that denture up with our pickup material and you seat it in the mouth, we're going to have what you see here on the right, the excess material. We want it to come out of there. So you're going to get excess air to come out, as well as excess material. If you don't do this, that material is going to go everywhere underneath that denture. And hopefully you did do a good job of putting Vaseline there. Otherwise, you're going to be grinding that flash off, and it's going to be a nightmare. So a simple little thing to do, quick and easy to do. I also would throw a little Vaseline out here. Makes it easier to just what I would do is once you seat it, wipe that off so you don't even have to address it, other than just polish it. Notice here too, this is something I used to do all the time, is especially for our elderly patients, is create a bit of an area where they can get their fingers in and to get a hold of something to lift up on that denture to take it in and out. So again, think of your patients. This is very hygienic. I left it very hygienic. There's not a legend here. All right, so now we're ready. We've got our room. We have our spacers in place. We have our black inserts into the locator housing. If you really get concerned, you can throw a rubber dam over that as well. Might be an overkill, but I tell you what, the time you lock one in, you'll never think that doing a rubber dam is an overkill. Just a rubber dam, but the size of a dime is all you need, maybe the size of a nickel at the max. So here's a little tip for you though. When you fill in these areas, don't fill it full because you got this, you got the abutment, you got the housing. There's a lot of material there's an object that's coming into that pool of acrylic here. So to get it 2/3 full would be plenty. And then invert it, seat it in the mouth. You're going to make sure you see excess come out here. And then, like I say, I mean, whether you wipe that off now or you go ahead and cure it, either way, I like to use a dual cure. If you use a self cure, give it plenty of time. Don't just squirt some on the back of your hand or put a little on a gauze there. And oh, yep, it's hard. It's ready to go, because what can happen is that denture can act as an insulator to keep the temperature of the mouth from that acrylic inside the denture. And maybe, on your back of your hand or the material here in the lingual is set up, and it may not be set up internally. Light cure is a great way to go. However, some lights don't penetrate real deep. So don't rely only on the light cure. So moral of the story is use a dual cure. Light cure is going to help you to get it set right away, and then give it plenty of time. If the set time says 2 minutes, give it 3 minutes. What's another minute? I tell you what it is. If you take it out too soon and it's stringy, you're gonna hate it. You're gonna say, "Yep, I should have waited longer." Guess how I know? You got it. Been there, done that. Now, sets up. You remove the denture. Then you're gonna backfill with this little tip that they make. You add a little tip to it, and you just kind of backfill any voids. Okay, just so you have no food traps. And then now we're gonna remove that black processing ring. So what we're going to do here is that tool has the one end of it. You just push it inside, lean a little bit, and it pulls out that insert immediately, very quick and easy. And then what you do is you just turn, then you turn this knob, and a plunger comes out and pops that little insert off the end of your tool. Then you unscrew that off of the tool completely that you were just using. And this has a little hole on the end of it here. And this is your new insert that your male insert. So you're going to put that on the end of your tool, and you simply snap that into the denture. And that's it. Now you've replaced it. I would also suggest probably start with the lower retentive of it first. Usually that's enough to keep a patient happy. But if they go, well, is there anything else you can do? Yeah, you can bump it up to the medium one. But if you start with the 5-pounders, they may not get it out of the mouth, or if they go, well, anything else you can do? I mean, psychologically, you made it, they got a couple of tighter, a little bit tighter, but if it's too tight, they're not going to be able to remove it, and it's not going to do its job really as functioning like it should. All right, so that was retrofitting existing denture. Great service to do for a patient, very rewarding. But now let's talk about the patient who has the denture that you're wanting to fabricate them a new denture with locator implants. Now you can have the lab. I'm going to show you a technique where the lab can do the entire, processing all the housings into the denture. There's an option where you could do it yourself, but we'll talk a little bit about both of those. By the way, I put this go to YouTube. I was blown away when I first started doing some locator overdenture lectures. This was years ago. But even I did this just the other week. I went in there because I'm looking at their new fixed. There are hundreds of videos that people post. Some aren't always good, but there's some really good, helpful tips and pearls. Really great things. Zest Anchor. They have a lot on their website. Dr. Michael Shearer, as always, you see him post on LinkedIn a lot, techniques, great things to watch. You'll learn a lot from someone like him. Great information out there. So you don't have to just get what I'm sharing with you today. There's a lot of information out there to help you. We're going to talk about impression options. These are going to be analog protocols that we're covering tonight. It can be an implant level impression or an abutment level impression. So let's cover both of them. So an implant level impression would typically mean that the surgeon returned the patient to you with healing abutments in place. So you remove the healing abutments. Typically, closed tray, probably acceptable. Open tray is always, open tray impression copings are just preferred usually all the time. It's just, they're just more accurate. But you have to find your own comfort level. The implant level impression technique, then, of course, would be to seat the impression copings, make sure everything is seated. You may need to take a radiograph to make sure they're seated. Then you're going to inject your medium to heavy body PVS material around that, load up the tray, seat the impression tray. Then when it sets up, obviously remove the tray. And the laboratory then would pour the impression and put the analogs in, et cetera. Using what's called an abutment level impression, one of my longtime dear friends of mine who's a master in removable prosthetics, Jane Hartner, has talked about these little upside down martini glasses. We know where her head's at. These are the abutment level impression copings that are available, and they snap on to the locator, the gold locator. And then that basically acts like a closed tray impression, so that when you seat those, take the impression, pull the impression out, that metal upside down martini glass is embedded in the impression. Then you can send it to laboratory, or if you're going to want to pour the model yourself for whatever reason, you need these analogs as you see here. And then the lab or you would snap the analog into the impression and pour the model. Typically, the lab's going to do this most of the time. So then from that point, then the laboratory would go ahead and fabricate the denture, maybe do some try-ins. If you're going to do a wax try-in, they can actually put a housing inside the base plate of the wax try-in, so you can actually snap that into place. Again, at this stage, you want to work with a laboratory that knows what they're doing with overdentures. NDX has over 50 laboratories, and I believe most all of them are very versed in implant prosthetics with overdentures. I'm going to switch gears on us a little bit here, and then we're going to get into some Q&A. Hopefully we got some good questions there, and hopefully I have some good answers for you. So what I'm encouraged about is what we're seeing now is the locator fixed. And I tell you, I think this can be for some patients a real game changer. We know that there's a lot of options for the edentulous arch out there. The dentures, we've been talking about the 2 implant and the 4 implant. And this is what we're going to talk about for the next few minutes is a locator fixed. Of course, the other option is, an all-on whatever. But I think, these numbers down here, these are provided by Zest. These slides have been provided to me by Zest. And these are just some ballpark figures. But, it does give someone the opportunity to get into a fixed prosthesis. I'm not saying this is inexpensive, but comparatively so, it could give patients something they're still looking for and keep it in the price range. I mean, your job as a clinician is to deliver the patient, meet their expectations, deliver them with the best that dentistry has to offer that they can afford. Not everyone can afford, what you might feel is the best, but let's just do, we have options out there. And I think really my goal this evening was to share some options with you and give you some tips and pearls to, be successful with these different options. So what this fixed locator, hey, it looks pretty same what we just been looking at, right? Well, what's different, this is exactly the same. The male abutment that goes into the implant has not changed. What's different is the insert is a different material. It's designed differently. So it's completely different than what we were looking at previously. And then the metal housing is significantly different in design. May not look a lot like it to you, but trust me, when they engineered this, there's a lot of thought that went into this and design and geometrics that makes this work. And so how it works is that our locator, we wanted it to have some movement and some give that housing could rotate over that insert to allow the prosthesis to move to distribute the loads that are generated during function. So what's different with the fixed is it doesn't move. This insert and the housing is locked on to that abutment. The patient cannot remove the prosthesis from their mouth. You're the only one that can do that. The other thing is that it can utilize really minimal inner arch space as compared to doing an all-on X type of a prosthesis. So what I also thought was really cool is now let's thinking our little minds back, take it back a little bit to when we were talking about the AP spread. And we're going to do this would be a new denture for a patient, let's say. By the way, you can retrofit uh, a patient's existing overdenture to a fixed. I'm going to cover that in a couple of slides here. But what I'm sharing right now would be a consideration for you that let's say patient's edentulous, you're going to do 4 implants, you're going to do this fixed locator to start right off with, but you want to get some AP spread. And maybe because of numerated sinuses, you got to stay in front of the sinuses. And so you want the implants, what your implants clinicians are doing, is the surgical implant clinicians are doing, is are angling these implants to create more of an anterior posterior spread, as well as avoiding anatomical feature landmarks that are challenging for them, be it the nerve or the sinus. But they make a locator multi-unit abutment. So and it's not for every implant system, but for the more popular ones, the MUA fits into the implant, it gets screwed through here into the implant. Then this housing goes over that, and then the locator connects into the top of the multi-unit abutment. And this is your cuff height, if you will, here. So that's a neat option. So here's a nice snapshot. So when we look at the top row here is a locator, the one we've been talking about all evening. The bottom here is the locator fixed. So this is the same. Processing insert is the same. The pickup method can even be the same, okay? But what's going to change now is going to be really the materials or the componentry, better said, the housing and the inserts are going to be different, okay? And then if you're going to retrofit, so if we had a patient here that had 2 implants and you place 2 more implants and now you want to retrofit this, then what you would do, doing the techniques I showed you before in the presentation, create an opening, picking up the locators themselves, you just be using these components, not you'd use your your processing insert. But then what you would do is once you process, you insert these inserts into that, and then you're going to cut the peripheral borders back, remove the palate, cut the lingual borders back, turn it into that hybrid, and you're going to have to backfill the integular side so it's not a concavity. A concavity is going to be nothing more than food being packed in there, food trap. So you're going to need to do like a reline, could be a chairside reline, or maybe you do a wash impression, send it to the lab, have them do a reline on it. Again, work with your laboratory that can guide you through these steps. The again about the fixed is that the amount of inner arch space. So a lot of times you don't have to have as much bone reduction as we see in some of the other types of fixed options for an edentulous arch. So that could be very, very beneficial because maybe the patient doesn't have the bone to remove to help with that. Especially think about a maxillary arch when we're talking about the transition line. And what we know from what I've learned through my days and years, my years within sequence and in full arch, all on X type of prosthetics, is that transition line where the prosthesis meets the alveolar ridge needs to be 3 millimeters above the highest lip line, the highest possible height the patient can bring their maxillary lip. And so to do that, you need to have inner arch space for the prosthesis, which many times you're going to have bone and alveoloplasty done, remove bone, so that you have room for the prosthesis. Whereas with this fixed, you don't necessarily need to do that because it's a different kind of a prosthesis to a degree. Again, just some of the commentary from the manufacturer on it. But it can be something I would say encourage you to consider looking into. And again, there's a lot of great videos on this information on YouTube. And then, so what's neat about it is they got some new tooling. And this device, to me, is brilliant. What you're looking at here is this is like a long trigger. you're going to pull that, and what's going to happen is when you're seating it, this attachment's just, you push in, and it kind of has a snap fit. It's got a plastic pad on it. It's about the size of like a bent over toothbrush in a way. And you seat the denture over the abutments, and you take this attachment and a tool, you lay it over the attachment in the mouth, over the tooth, and you just, you kind of lay it on it, you squeeze the trigger, and it snaps, and the movement, and it pops the denture, engages the insert into the housing. I'm sorry, the insert into the onto the abutment. And you just go around on each implant site, and you just put that on top, squeeze the trigger, and click, 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 and it's locked in. Patient cannot remove it. For you to remove it for hygiene purposes, what have you, there's this little cable here. It's hard to see. This is a little cable that fits in the same way. So you remove that, drop that into place. You just get that little loop over the distal extension, come up underneath the denture. It's very simple, goes around the back, underneath the prosthesis. You just kind of lift up a little bit and just pull the trigger, and it pops it up. You just go around, you remove it, 10 seconds at the max. So again, a pretty neat option. And I only have a few slides left, so unfortunately my battery didn't quite hold out. Now, when you're doing a fixed locator, you still can, if you're starting from scratch, I mean, you can do zirconias with this, you can do your nano ceramics. So it's just as a nice adjunct. It's a nice in between from an overdenture to an all-on-X to provide a patient with something that might fit their pocketbook a little bit better. Even though I say you don't treat the pocketbook, I mean, there's reality, right? Okay, and we'll take some Q&A. And I'm going to put this screen up so you can, again, have my email address, contact information. Please feel free. I do the best I can to get back to you as quickly as possible. I do travel a lot. I'm in surgeries a lot, but I promise I will return your emails.